Hi, and thank you very much for joining us. This is the May 28th, 2014 Plastic and Reconstructive Surgery Journal Club at St Vincent's Hospital in Sydney. My name's Damien Marucci. I'm a plastic and reconstructive surgeon. This is Dr. Ryan Prasad, one of the plastic surgery registrars. So today we did the usual 4 papers. So the first paper which we did, Ryan, was looking at
the augmentation of intraorbital volume with fat injection.
So this paper was out of Cleveland, Ohio, and was published in PRS in May 2014. So Ryan, what was the rough gist of this paper?
So this was looking at the problem of enophthalmos, which is a problem that plastic surgeons face, particularly with traumatized orbits. And the procedures that we have currently to correct enophthalmos include fairly invasive surgery, dissecting beneath the globe and placing a little implant in to recorrect the orbital defect. The orbital space widens with an orbital floor fracture, which means the volume of that place increases and the retroorbital fat falls beneath into the maxilla, and that sucks the globe back, which causes the enophthalmos, and that's one of the causes. And this proposes a different method of correction by actually augmenting that space with some autologous fat taken from the groin of a rabbit in this case. And it showed that by injecting fat along the orbital floor and along the superior part of the orbit, they were able to provide some volume into that space and actually create protrusion of the globe on the side of the injections, as well as increase the volume of the orbital space.
Yeah, this was obviously a very important study and raises a potential new technique for treating enophthalmos in a minimally invasive way using fat grafting. One of the concerns people have about fat grafting around the orbit, especially inside the orbit, is a potential for fat embolus or damage to the globe or muscles or nerves in the area leading to blindness. That's why this study was done in an animal, and they went to great lengths to assess the visual acuity or visual function of the animal during the study, and they didn't find any evidence of damage to the retina or problems with visual evoked potentials or whatever. So what did people think about this paper?
Well, it's a good study in the sense that it proposed a nice, minimally invasive method or less invasive method of this very complex surgical problem. We felt, though, that it didn't really answer the question. I think people will still be apprehensive about the potential risk to vision, as well as the potential risk of stroke and fat embolus. Just because in the rabbit model it showed histologically and through visual evoked potentials that there was no damage to the nerve, I think it doesn't really address the problem of potential adverse effects, as well as the inability to control how much volume you use and how much proptosis you achieve.
Obviously, a lot of surgeons would feel quite wary about injecting fat posterior to the or in the posterior orbit blindly. So it'll be interesting to see whether this technique is eventually applied to human subjects. Okay, that was the first paper. The next paper we did was augmentation of tendon healing with an injectable tendon hydrogel in a rat Achilles tendon model. And this is also from May 2014 from PRS. And so what was this study about?
So this was looking essentially at tendon healing and how tendon healing can be facilitated to try and prevent some of the complications that we see people coming back, particularly with hand injuries, coming back with tendon with corrected tendons that have ruptured and that require re-exploration. And what this study did was used a human cadaveric tendon-derived extracellular matrix that was produced in-house, and using 36 rat models, one Achilles tendon was injected with the hydrogel and the other Achilles tendon was injected with a saline control. And at 2, 4 and 8 weeks, tendons were sampled for biomechanical strength as well as histological analysis. And they were able to show at the 4-week time point that overall failure of the tendon when it was loaded was actually 28% better, or 28% less failure in the hydrogel group than the saline control, as well as more proliferation of collagen in that hydrogel group than in the saline control. And it was thought that at the 4-week time point the tendons had essentially reached their native strength, and that's why there was no difference at the 8-week time point, because both groups had reached their native strength.
Yeah, so they did make a big point about their significant results, saying that it occurred in the crucial 4-week period, although they weren't able to demonstrate any other changes either at an earlier time point or a later time point. They said they did a pilot study looking at 1, 2 and 4 weeks, and obviously they may have noticed the improved strength or the significantly improved strength at the 4-week mark, and then hope that that would be replicated at the 8-week mark is what I'm guessing.
Yeah.
And unfortunately it wasn't. The other thing about it, it's a bit, one of the things we were discussing, it's a bit difficult to see how clinically we would be using this, say, for your standard tendon repair. This isn't a tendon that was cut completely and then repaired with sutures, which is the more typical scenario we're dealt with. Even when you're dealing with a partial tendon laceration, which you've explored in the hand, most of us would just put a simple suture in or whatever, and it would be interesting to see if they could develop a model which was more clinically relevant to patients undergoing tendon repairs, like whether they put some of this hydrogel on the inside of 2 cut ends of tendon, which they put back together in an animal model, and then seen the strength of the repair at various time points afterwards. Were there any other comments that people had about it?
Yeah, I think the main issue was with the injury model. It was a longitudinal incision, which isn't really reflective of what we see in clinical practice.
Yeah. Okay. All right. Okay. Then the next study we looked at was Avulsion Brachioplasty Technique Overview and 5-year Experience. This is from a private clinic in the United States and published in the February 2014 PRS. So what was this paper looking at?
So this was looking at the cosmetic procedure of brachioplasty. Now this is a procedure that's increasing in popularity in the whole population, not just in the high weight loss group who have problems with excess skin. And I think the demands of the population are increasing in the sense that they want a procedure that has a predictable, reproducible scar that's well hidden, and that can be difficult to achieve. This is a paper that describes the 5-year experience of this centre, looking at 44 patients, and it describes the technique they've used in full detail, as well as how the techniques evolved over the 5 years. So the 44 patients were all female, and the technique is one of making a mark around a line that goes from the medial epicondyle at the elbow up into the mid-axilla, and the area to be excised is then pinched. It's liposuctioned out completely, and then the fascia in the skin is excised in the lips, and the skin to be excised is literally avulsed using a cocker clamp and pulled out from proximal to distal. The idea is that the vessels and the nerves, as well as the lymphatics, are preserved, taking only fat and skin, and in this way you get minimal bleeding and minimal post-operative complications of swelling, as well as bleeding and
seroma was the other one. Yeah.
Yep.
And so their results were very interesting. Although they had over a 50% complication rate, the kind of complications they were looking at were very minor scar revisions or minor wound dehiscences. But they said that in terms of major complications, they really didn't have any major significant complications at all.
No.
So their conclusions were it was a safe and effective technique with a high patient satisfaction, a low major complication rate. This is certainly a technique that I use. I use the technique which is described by Rorik. In this technique, they make the point that a proximal to distal avulsion is important, whereas most people I know who do it use a distal to proximal just because it's easier to sort of pull down with the patient's arm abducted and with the elbow flexed. What did people think about this paper?
Yeah, overall it was a very positive response to the paper. I was certainly very impressed with it. I thought it was a very well described technique, and it had a very sound theoretical basis, and I think the results are very good. Even though the complication rate was 50%, they did make the point of mentioning that anything was a complication. Even small wound dehiscence that just required serial dressing changes was noted as a complication, and that's why it was so high. But certainly no acute return to theatre for post-operative bleeding or infection or anything or too severe like that.
Okay, the last paper was a classic paper. This is from 1958 from the British Journal of Plastic Surgery, The Levelling Effect of Z-plasties on Linear Scars of the Face by Marino. This was a great paper. So what was the gist of this paper?
So this looked at what is still a very complex surgical problem, and that are depressed scars in the face. They're asymmetrical, they're unsightly, and they're very difficult to treat because it's such a cosmetically sensitive area. This proposed a theory using multiple Z-plasties to make to make use of perpendicular tissue to lengthen that scar and prevent the defect from shelling in again. And was used to a great success. And he makes 6 points in this paper. One very important point is to not use it on acute traumatic wounds, but rather wait for the scar to evolve, and if it requires correction, then excise the scar, arriving with a linear defect, and then imbricate the borders of that in the cutaneous layer in order to achieve the correction of the scar. The theory behind it is that in the face, scars are best hidden perpendicular to the direction of propagation of muscle movement rather than the true lines of Langer. Langer's lines are based on a static cadaveric model, whereas the face is a very, very dynamic area and has a lot of movement in many different directions. And over time, the lines that we see in aging people form in perpendicular to the propagation of muscle movement, and that's where these scars are best placed.
Okay, well, Ryan did a fantastic job presenting the papers this evening. So for those of you who are there, I hope you enjoyed it. And for those of you watching now, thank you for listening. Okay, bye.